Bacterial meningitis by Keely Staten. Bacterial meningitis occurs when microbes invade the subarachnoid space. This leads to inflammation of the meninges, and the inflammation occurs because the bacteria replicate and attract highly activated leukocytes into the cerebrospinal fluid. The most common causative organisms worldwide are Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenza. These organisms were identified during a 2016 study which established and analyzed a global bacterial meningitis database of reports from 66 countries. Incidence can vary by age, with strep pneumoniae being the leading cause of meningitis in older adults. Neisseria meningitidis occurs mainly in children and young adults, and Haemophilus influenza occurs primarily among unimmunized children and infants who have not yet completed their immunizations. Cases tend to spike during winter months in both northern and southern hemispheres, and these spikes are thought to be due to the increased spread of infection due to people living in close quarters during these times. The most common symptoms are fever, headache, nuchal rigidity, and altered mental status. Presentation can vary with age, with infants presenting with irritability, lethargy, poor feeding, vomiting, and fever. This can be difficult to diagnose in infants because these symptoms are nonspecific and can be confused with other illnesses. Children often present with signs of meningeal irritation such as neck stiffness, headache, and photophobia. Adults typically present with at least one symptom indicative of meningeal irritation, and only a minority will present with the classical triad of fever, nuchal rigidity, and altered mental status. Early signs are typically nonspecific, such as fever and malaise, and the later symptoms of phonophobia, photophobia, vomiting, and neck stiffness develop due to increase in meningeal inflammation. Physical findings, such as Koenig sign, Brzezinski sign, and nuchal rigidity, can help in the diagnosis. With the Koenig sign, the patient's leg is passively extended while lying supine with the thigh flexed on the abdomen. If the patient resists extension of the leg, this is a positive Koenig sign. For the Brzezinski sign, the clinician places a hand on the patient's chest while the neck is passively flexed. Flexion of the knees and hips is a positive Brzezinski sign. For nuchal rigidity, this is seen when a patient is asked to touch their chin to their sternum and they are unable to complete the maneuver. A 2010 study found that nuchal rigidity was the most sensitive of these physical exams. Definitive diagnosis is made by examining the patient's cerebrospinal fluid. It's often examined for the presence of white blood cells, protein, glucose, and is also tested for culture and gram stain and PCR. Some of these tests are more clinically relevant than others. A 2012 study determined that both the protein and white blood cell concentrations were significantly increased in bacterial meningitis when compared to the absence of meningitis, as well as viral and cryptococcal causes. Glucose concentrations were not found to be clinically relevant, however. And while gram stain and culture can help in the diagnosis, polymerase chain reaction, or PCR, has been found to be the most rapid and reliable means of determining the causative organism. Imaging can help differentiate between meningitis and tumors or abscesses of the central nervous system, which can have similar clinical presentations. On MRI, meningitis appears as diffuse meningeal thickening and hyperenhancement, as you can see in this example here. Empiric antibiotic therapy is key and should be given immediately following collection of the cerebrospinal fluid and blood cultures. The empiric antibiotic is chosen based on the patient's age, exposure, and any pre-existing diseases. Adults and children who are otherwise healthy should be treated with third-generation cephalosporins and vancomycin. Adults over 50 should also receive ampicillin. Patients with impaired immunity require vancomycin, ampicillin, and cefepime or meropenem. And those with healthcare-associated infections should receive vancomycin plus ceftazidime, cefepime, or meropenem. If the results of the gram stain and culture, or PCR, reveal a specific bacterium, the antibiotic regimen should then be adjusted to target that pathogen. Addition of corticosteroid therapy has also been shown to reduce mortality by reducing the meningeal inflammation. For prevention, vaccination is key. The CDC recommends meningococcal, pneumococcal, and Haemophilus influenza type B vaccination beginning at 2 months of age. Meningococcal vaccine is also recommended at 11 years of age with a booster dose during late teens, and since the development of these vaccines, annual disease incidence in the U.S. has decreased more than 50%. Printable color-coded vaccination schedules are available on the CDC website.